Um, oh, the facial. Is my PowerPoint showing?
You are visible and audible.
Okay, that's great. So hello everyone again. My name is Ibrahim Sudan, and I'm from Medicine Sudan. So today I'll be talking a bit about Sudan's COVID-19 response and maybe from a perspective of the health system, what really did happen throughout the pandemic. Currently, we have about 42,000 cases that are COVID cases, and the number of active cases has been it has been decreasing from the December or January 2021 high that we had. So moving on, just giving some background, the pandemic started with a significant rush of cases. This was back in March and April, due to a political transition and also due to the failing economy. We faced huge challenges in order to limit the spread of the pandemic. And this could be shown due to the fact that also the health system was underfunded for decades. And in that period, and a lockdown was enforced back in May, but it wasn't that effective. Why? Because most people were depending on their daily income so that they're able to keep on living. So the lockdown was imposed, but on the ground, as you can see, maybe that picture can show that people really are not able to keep up with these protective measures or even to stay at home during this period. So in the same well, speaking about the health information, there was very low surveillance, and at the same time, also contact tracing measures were almost absent during the first 6 months, because at that time there were many cases, and usually a patient only shows up when they're really sick. And there was also an issue with testing. The testing, COVID testing, was difficult during the first 3 to 4 months of the pandemic. So this actually underestimated the scale of how COVID impacted the population in Sudan. Okay, from a perspective of health workforce and accessibility, health workers have been trying tirelessly, working tirelessly on COVID-19 patients, and similarly with the issue of the testing measures, also PPE was very, or personal protective equipment was in shortage during that period. So this also made it very difficult for these health workers to provide the care that the COVID patients need, and at the same time, care for chronic patients, those suffering from NCDs, those who need dialysis, and so on, was very, very limited. Excuse me. Okay. So also at the same time, there were isolation centers that remained of very low capacity, and intensive care beds and oxygen tanks and power outages were very common during that period. There were also power outages. So moving on, in the midst of this crisis, it was paramount for the youth, voluntary organizations, and also foreign aid to move in. So youth came to support through volunteering projects and by I'm just sorry.
Ibrahim, you are currently.
Yes, yes. I'm sorry for the break. It was just that I just got a phone call, so I just had to probably leave it down for now. Okay. So youth have been working very tirelessly on this issue, and moving on. Okay, so moving on to the immunization program. Since then, the community awareness has improved, particularly in this year. And vaccines were first rolled out to health workers, and it's obvious to expect that most of these vaccines, or almost all of them, were out of like foreign aid, as you can see that picture. And one of the positive things that I could really see was that the distribution of these vaccinations only was through primary healthcare centers. So this was very helpful. It showed that everyone can really get the vaccine whenever they need it. So right now it's just about the awareness and trying to get enough people to get vaccinated against COVID-19. Okay, so in a conclusion, I think that the way of hope was really the ability ability that the community could really come together against the COVID pandemic. And at the same time, we did have like great improvement. I think that the factoring of primary healthcare systems, primary healthcare, I mean, in providing easy access to essential healthcare was sort of shown with these vaccine implementation. So yeah, currently Sudan has a vaccination percentage of 2.7% to 44,000 cases and 40,000 deaths. Thank you. I guess that's all for me. And yeah, back to you, Adham.
Thank you very much, Ibrahim. In case anybody didn't hear any specific part from Ibrahim's presentation, you can always ask him on the chat. And we now will be moving to our second presenter for today. We have Carly.
Yes, thank you. I will also share my screen with you. I hope you can see it now.
Yes, we can, and we can hear you.
Perfect, thank you. So I'm very happy to present my perspective of the COVID-19 pandemic from Austria and Germany, as I come from Germany, but I'm living in Austria currently. And in general, I believe the two countries and their almost universal healthcare systems are somehow comparable, judged from a global perspective. So I would like to begin with where it all began for most of us in March or spring 2020, where, like in many other countries, there was a lack of healthcare workers and personal and contact tracing with the new challenges. And in support of that, to support healthcare facilities and public health department, there were members of the armed forces who were deployed to help out with that, and medical students and retired doctors were called upon to also help out. And indirectly affecting the system was also a shortage of protective medical equipment, such as face mask or disinfectant. And there were clinics which started to produce makeshift face masks, and some were donated by the public. And also in the industry, some factories rearranged their production so that they could produce some as well. In general, in terms of public health decisions and the adaptation of the systems, I think Austria and Germany mostly seem to follow one another somehow, which seems reasonable, looking at the curves of COVID infections in both countries. And these graphs show the confirmed cases and the deaths due to COVID in Germany and Austria in the form of daily changes to the numbers. And then consequently, the imposed lockdowns were also similar, with a few differences in the exact timing or length of lockdowns, and curfews and other restrictions could also differ, because especially in Germany, they are often federal decisions instead of general ones by the national government. And in Austria, our fourth lockdown is ending today, fortunately. Then when it comes to the adaptations in the health sector itself, the German Interdisciplinary Association for Intensive Care and Emergency Medicine, in cooperation with other institutes and federations, set up an online intensive care register, which could be used to view daily updates of hospitalized persons and bed capacities in intensive care. Then in June 2020, contact tracing apps were released in many countries, including Germany and Austria, which were designed to inform users if they had come into contact with an infected person or if it may result in an infection for themselves. Then in September, there were also new full-time positions created to combat the lack of personnel, but there was a slow progress because many newly created positions could not be filled, unfortunately. And additionally, scheduled surgeries were cancelled or postponed to create additional capacity for the care of COVID-19 patients, and appointments were cancelled also by patients. Some of them were shifted to telemedicine settings where possible. In general, I believe that insurance, as in financial protection of the patients, was not interrupted much in general, but quality healthcare inevitably decreased with the management of COVID-19, which required a lot of attention and energy, of course. And also throughout the pandemic, the most limiting factor forcing stricter public health measures has been the capacity of intensive care units, particularly regarding skilled healthcare workers. So some patients were transferred across the country, sometimes even to other countries, often with the help of the armed forces, which is also shown in this picture. Trying to test as much as possible and imposing occasional restrictions seemed like the strategy, with moderate success, I would say. And as a remarkable example, especially two Austrian federal states have made PCR testing easily accessible. They offer free gargle testing equipment to any residents in supermarkets, where they also have collection boxes, and in a very convenient way, people can gargle at home. While identifying themselves, then they can drop off their test tubes and receive their results via email in 24 hours. And this system is about to expand. In the vaccination progress, Europe had access soon after their availability, and they were offered in a prioritization scheme, but vaccine hesitancy has become an increasing issue. Almost half of the population felt uncertain about their safety or scientific evidence, so only about 68 or 69% of our populations are vaccinated right now. And coming to an end, looking into the future, there have been many discussions around vaccine obligations now in Austria and Germany. Austria has decided to impose a general one starting in February 2022, and Germany will have a limited version of that starting in March. I do wonder how long we can surf the waves, though. Thank you very much.
Thank you very much, Carly, and for your catchphrase. And I hope the conditions in both countries be better. And thank you for your presentation. With this, we will be moving to our third presenter today, which is Lily.
Hello, everyone. Good morning or good afternoon, wherever you are in the world. Today, I'm going to talk about Panama's response to COVID-19 and its impact in UHC. So for a little background, in the past 15 years, Panama has experienced a stage of accelerated economic expansion with an average annual growth rate of its gross domestic products that exceed 6%, and sometimes it was even above 10. But despite this exponential economic growth of Panama, it's still a country that only invests 5% of its GDP to health expenses. And as an outcome of this unequal distribution of the incomes, even before the pandemic, the public health system of Panama was already struggling to leave no one behind, with specific issues such as inequality in the distribution of human resources, the lack of medicines in the public institutions, poor infrastructure of public healthcare centers, and all of this contributed to deficiencies in the public health services. Then how did Panama face the COVID-19 pandemic and how it impacted UHC? Well, this is what I was talking about, inequalities before the pandemic. So this is how the COVID-19 pandemic looked in Panama until October 30 of 2021. So Panama continues in the first position among countries in the Americas with the highest accumulated incidence, with 10,890 accumulated cases per 100,000 inhabitants. So general measures that were taken since March of 2020, where the cases of COVID-19 started to appear. A measure of total quarantine in the whole country was implemented, and circulation restrictions were implemented by gender and by days, and also by hours. You could only go out for 2 hours a day. If you were a woman, you were only able to go out Mondays, Wednesdays, and Fridays, and so on. So December to January 2020 to January 2021, we had curfews. Then since May 2021, a gradual opening of the country by blocks was implemented. So these were general measures, but talking about public health strategies or actions that were taken during the pandemic. First, on early preparedness and response to COVID-19, where sanitary controls were established at the points of entry of the country. Laboratories were prepared for the testing, and also the installed capacity of hospitals was expanding by providing beds, supplies, essential equipment, etc. Also, strategies of risk communications to the population, where communication material was elaborated for the general population, to mitigate all of the effects of the pandemic by promoting the protective and preventive measures. And even communication materials were prepared for migrants and for indigenous people so that everyone had access to the information in their own language. Also, active search and follow-up of positive cases and the identification of their close contacts was done so that we were ensuring that they were isolated and to monitor their compliance with health measures. Protection of vulnerable populations also, and where groups of like community health promoters were designated to these vulnerable populations so that we could take care of them during the pandemic. And last but not least, vaccination. As October 30 in Panama, at least 55 out of every 100 people have a complete vaccination schedule. So this was like a big achievement. So final considerations, even when all of these actions were implemented, our health system were still not enough to handle the high loads of cases. We even had hotels and convention centers to be transformed into COVID-19 centers for patients because of the lack of capacity of our public health system. And also the strict measures such as the social quarantine made it too difficult for people with informal jobs or living in vulnerable conditions to live properly during the pandemic. So this perpetuated social inequities. So these are my final considerations. And if you have any question, I am here to answer them. Thank you.
Thank you very much, Lily, and for your presentation. If anybody has any question to Lily, you can always ask in the chat. And lastly, we have our last presentation from Uma.
Hello, namaste everyone. I am Uma and I will be speaking on behalf of how things have been going on in India. So I would like to start by discussing the timeline. As the timeline was pretty similar for everyone, India faced the turbulence a little later during the first wave. And I believe this chart can describe that. Till March, we were reporting almost none to very little cases because of early lockdown, which was started in March and was continued till the end of May. There were multiple phases of lockdown. However, as lockdown has to be released because of the economic inequalities that our country was facing and the lack of facilities that we had, we saw an exponential rise in the number of cases over July, August, and September, September being the worst, where we were reporting almost 100,000 cases a day. This, however, was complemented by the national lockdown, as I said, which was conducted in 4 phases, starting from 25th March 2020 till the end of May. However, this was the nationwide lockdown, and we had multiple lockdowns with each federal state. There was an infection tracking app that was developed by students of the Indian Institute of Technology in India, which was very helpful in combating COVID-19 and was made mandatory by the government. However, the second wave hit really bad, as it did everywhere else, and the cases were more than exponential compared to the first wave. However, during the second wave, the silver lining was the vaccination drive, which had initiated in January. From January to July, it raised up to 10 folds, and we were able to do a lot of vaccinations. However, the percentage still remains to be 30%, while that also contributes to the fact that India is the second most populous country. Testing and research was a constant process which went out through about 200 labs in the country, where we had CBNet, antibody-based kits at home. We had drugs, we were introducing hydroxychloroquine and chloroquine, exporting them from all countries. And then we had multiple strategies for COVID-19 vaccination drives. These were, however, loaded with challenges because healthcare system, our administrative management, and our economy, all three were high pressure. So let's see what happened to the healthcare system. Our healthcare system lacked medical preparedness, though everyone was aware of the pandemic coming in January. India was not ready until April, though that did not show its effects in the early part of the pandemic. It started to show its effects later. We lack infrastructure, hospital care, facilities. We have only about 0.8 doctors per 1,000 people. And there was a lack of protective equipment that could be made, as most of the things were imported from China. And due to the geopolitical situation, there were multiple issues faced with that. Our population density continues to be one of the second most things for us, while it usually forms the backbone for our economic growth and for the continuous development of the country. But it made distance mandates very difficult. It increased poverty. It was more dangerous for the high-risk citizens, especially diabetics in India. The equity of resources was not there, and cost of treatment, India having an out-of-pocket healthcare model, was very difficult. What now? The country has been mobilizing resources. We are focusing on digital health. Very recently, our Prime Minister also launched full health coverage under the Ayushman Bharat Health Scheme. Our budget allocation has somewhat improved from previously 2% of the GDP to a little more. And we are focusing on collaborations and participation. However, if we sum it all up, UHC still seems like a long way to go. And that is because of all the facts that we've stated till now. But we are still trying, and I believe that is one of the biggest strengths that we have. Thank you.
Thank you very much, Uma, and to all our great four presenters. And now we will be moving to our panelists or speakers. First, I'll be asking to reflect on these four presentations, mainly to highlight the potential causes for, let's say, each case, and the methodologies that can be used to improve the situation of those unprivileged cases and to sustain those fortunate cases. I will be asking just any of the panelists. You can start by raising your hand and I will be giving you the floor. Okay.
I can start if you want. Oh, please,
Okay.
Rob, go ahead.
Oh, go on. You kick off, Dennis. I'll follow you.
Yeah. Okay. Great. Thank you. Thank you very much, and thank you very much for to Akito first, because his presentation was very informative, and always good to see how UHC 2030 remains at the highest level in terms of mobilizing the world leaders and the forces at the planet level for universal health coverage. With regard to the presentations, I think that
Doctor, you are.
Yes.
Yes.
Can you hear me? Yes. Okay. So you regarding the presentation, I have to say that indeed this presentation and the result reflects certainly the difficulty of the situation in the countries. But what we can say is that whatever the situation, the initial situation of those countries, we see that it was difficult in all of them. And in all of them, there were at some point decisions that needed to be made in order to really try to stop the progression of this pandemic. And it was not always for medical reason, but also for economic reason. And the last presentation on India has shown how these two elements were linked in that country, where the progress, the obvious progress that has been made in the last decades were hampered by the pandemic. The second point is the situation in all those countries. There was a kind of evolution over the last 2 years, with periods where things were going more or less well, and also period where things were getting worse. And it was the case in Austria, in Germany, it was the case in India, it was the case in Panama as well. So it means that we have to make sure that what is put in place remains flexible enough to get the attention and the resources that the current situation requires in terms of fighting this pandemic or the next one, or maybe the next phase in 2022. Maybe we will have a 6th or a 7th wave. So I mean, this is really something that is important. And for me, one of the key of that is we have two things. The first one is the capacity in terms of economic power and reserve that the country has to overcome that in the frame of the international context, the banks and all these kind of things. But also what is certainly important is that we have the mechanism in the countries, we have more effective mechanism in countries to really not only respond, but also take the pulse of the population, and also be really willing to hear what the population has to say, because they are the first to suffer of the disease, but also of the consequences of the economic measures that are taken for their health and for the sake of the country. That's what I wanted to share with you as a first set of remarks. Thank you very much.
Thank you very much, Doctor. And now we'll be moving to Mr. Robert.
Yes, thank you very much indeed. And thank you for the fascinating presentations from 4 different countries and 4 different continents of the world. And for me, it really brought home to me actually the similarities that we're all facing. And, you know, I think countries at all income levels all across the world have been obviously been hit extremely hard by COVID-19. And I think it's almost provided the ultimate UHC test for all our countries. And I think, as I say, there were amazing similarities with all the presentations in terms of it hitting all our health systems, you know, right across the spectrum. So you can see similarities in terms of lack of health workers, lack of infrastructure, lack of equipment. Obviously, when we started this, lack of preventive measures to be able to deal with it. None of us started with vaccines, but now all countries are trying to increase vaccine coverage in the same way. So it really did bring home to me that we are all in this same boat together, and that we're all trying to deal with it in the same way, recognizing the great financial constraints we're working under. And obviously the very difficult decisions that governments are making to try and prioritize what they can do to tackle COVID, whilst also dealing with the burden of disease and the displacement of other services. So a number of you sort of mentioned, that other services have perhaps had to be sort of scaled back as, capacity has been increased to deal with the COVID-19 pandemic. So perhaps just one or two things that sort of came up from each of the presentations that I picked up on. Ibrahim, you mentioned from Sudan, the situation, that this crisis hitting you in other crises affecting the country, the problems with the economy, as you called it, the tricky political transition, and recognizing the difficult political situation that you've been dealing with there. So you've had this sort of almost like treble crisis of the pandemic, the political situation, and the economy, and the difficulties dealing with that. So our greatest sympathies to you there. But I think as well what you mentioned, and is absolutely right, the amazing solidarity being shown by the healthcare community with the population, the fact that everyone's been rallying round. And this has been a feature across the world. We did research on solidarity in tackling tackling the COVID pandemic, and amazing solidarity being shown by health workers going in to risk their lives on a daily basis to protect the population, and how that has been appreciated by populations across the world. And I think really demonstrating how access to healthcare is so important to populations, and just doubles the case for universal health coverage. The people expect this. And so even though it's been a huge challenge, I think, for all of us, this stands in good stead for improving our health systems coming out of this. Carlotta, a great presentation. Thank you very much from Austria and Germany, two very established UHC systems. Everyone sort of have high expectations that at this level of health expenditure, that we'd be able to deal with this. But just like in the UK, as we've been experiencing, you mentioned, that there has been this pressure put on the system, other services displaced, quality objectively going down for some of those services, and how that's been a challenge. But you mentioned the range of services that were being provided, from promotion and prevention right through to curative services. So this classic response of sort of trying to tackle this, with governments really sort of trying to tackle the full range of services that everyone benefits. And also very significant, you mentioning the importance of free tests, free vaccines. This has been government funding, public funding. We haven't seen this expectation that populations should be dipping into their own pockets to get testing and vaccines, because we know that in a public health emergency, that we're all in this together and everyone must be protected. So again, emphasizing the point of public financing to get out of this. Lily, you mentioned that that in Panama that you were having relatively low levels of health expenditure, I think about 5% of GDP, and how again this has become a challenge. That with modest levels of health spending, obviously your system's going to feel the pressure that much more quickly, and that the impact that's had. But that your government has recognised the importance of vaccines, and again, I think a very impressive 54% vaccine coverage. And one thing I picked up on, that you mentioned that all the information campaigns have been tailored to migrant communities as well. This very, very important. I think countries across the world haven't always been showing solidarity to all people living in their borders. And there have been examples of migrants being left behind, left out, even in relatively wealthy countries. I think a wave of infections in Singapore was really due initially to migrant population not getting the full coverage of the rest of the population. So congratulations to the government of Panama for thinking about the importance of covering migrant communities. And finally, Uma, you mentioned in India the extraordinary transitions there, where I think we were all amazed that the pandemic didn't kick off earlier there, and obviously the very draconian measures taken by the government with those early lockdowns. But then when that inevitably had to be lifted, the spectacular rises that we saw in the middle of last year, up to 100,000 cases a day, and how challenging that's been. But yet again, vaccines being seen as a way of dealing with this, and you know, the very impressive vaccine rollout. And obviously on a world stage, that creating some degree of controversy about those vaccines not therefore being available to COVAX, but completely understandable from your government's point of view. But then I think it does open up questions about the world's preparedness, and that perhaps we were too dependent on the expectations, the unrealistic expectations of getting so many vaccines from India, and that, you know, the knock-on effect this has had on vaccines going into COVAX. So you can see the interdependency, you know, that as countries have been trying to deal with this has had knock-on impacts across the world. And this doubles down on the call for universal vaccine coverage, and there's needing to be able to make more vaccines and make them more readily available across the world. And you mentioned, you know, the potential collapse of the healthcare system in India, you know, which, you know, historically has been underfunded, with only about 1% GDP per capita public health spending, and you know, that obviously being a huge challenge going forward. One thing I'd like to, perhaps when we get onto the more extended discussions, is to sort of get onto the discussions of what this has done politically in your countries, and whether potentially this has now, you know, really increased the arguments that you should be increasing public spending, and, you know, are your populations demanding faster progress towards universal health coverage? You know, we at Chatham House are very much looking at the, you know, the pandemic and saying, is this potentially creating opportunities for governments to accelerate progress to UHC, because their populations are demonstrably wanting better access to healthcare? So I'd be very interested when we get onto the discussions to ask that of you. Are you seeing the political appetite now for increased progress towards universal health coverage? But wonderful presentations. Thank you so much for that. I really enjoyed it. Thank you.
Very much, both of you. And I also see there's a comment from Dr. Dennis. Okay, so everybody, you can check the link that Dr. Dennis sent. And now we will be moving to more directed questions from me to you. And our first question will be, how can medical students participate in improving the situation, which is referring to the UHC situation after COVID? And who would like to start? Maybe we can start with Inash, since she is a medical student, or was.
Yeah,
Okay.
thank you, Adam. Yeah, regarding the question that you just asked, I believe that there are several aspects that we can analyze and that we can see of how can medical students contribute. And in fact, IFMSA, since the beginning of the pandemic, we have done several initiatives. Like, for example, we did a research project where we analyzed how medical students contributed in past medical emergencies. And it was really interesting to find out that, for example, right after World War II, even medical students went to the camps and helped out with logistics, and among other things. However, we also found out back then that in order to implement such protocols, there's also the need to take into account the well-being of medical students, and to make sure that they are given, let's say, the proper equipment in order to help within their respective medical health systems. What worried us the most was the medical education being left behind, which can be translated into a health workforce that is not sufficiently prepared to work within their respective health system, which of course can create a direct impact in terms of achieving universal health coverage, as the health workforce has a crucial role in it. So it's something that goes that we can analyze from a medical education perspective, of course. But what we try to do, since we have a huge network of students and national organizations, is to provide them with the correct information, or where they can find the right sources. Especially in the beginning of the pandemic, we worked a lot on this, on the misinformation, considering that this could be and can be, and it is, a huge issue. Especially we see that anti-vax around the world and in some European countries, it's very, we can see that it's a huge issue. So it's something that we try to raise awareness within our members. And besides that, we have several workshops, and some of them focusing on universal health coverage, so that we can bring this concept to our medical students, since in many medical schools, global health world is not exactly something that it is within our medical curriculum. And it's not, and therefore the concept of universal health coverage, it's not something that it is in the dictionary of every medical student. So besides all of this, the advocacy efforts from IFMSA side are also huge, since, for example, we have a policy document just focusing on universal health coverage and on its various aspects, from financial aspects until the health workforce. And we are present at important meetings within the global health agenda. Like, for example, we attended this past World Health Summit, which had a lot of important remarks regarding the pandemic that we are facing, but also regarding the preparation of health systems. And also, especially with the special session of the World Health Assembly, we are really looking forward to seeing how can this future treaty or international instrument, let's say, help also to advance this inequity that we can see all around the world, and that we could see within this presentation. Like, it's really something that we should feel very angry about it. How can, for example, Sudan, how can their coverage be so low when in Europe it is so high? Like, and I'm talking from my country, like my country's coverage on vaccination is really, really huge. And we are already talking about third boosters. We are giving the boosters when we see, and this has been highlighted by WHO multiple times, months and months ago, that and this is what we are seeing now. While some countries didn't even have access to the first shot, even with the COVAX mechanism and other mechanisms, we see that other countries, especially from Europe and within European Union, they are very, very high. And we are giving third boost shots. And it's, for me, it's really, I can find another word. It's crazy. It's out of my mind. How can we see, how can we even think of universal health coverage when this specific matter that is happening right now is, we aren't finding the proper mechanism? Of course, we are taking certain important steps, but it's not enough. It's definitely not enough. And it's something that we shouldn't take it lightly, because it's a very difficult and very hard situation, especially for those that are living through it. And yes, thank you. I spoke a lot, but I had a lot of things to say, and I would have more. But back to you, Adam.
That was very heartwarming, at least to say. I really felt what you said, everything from it. Especially, I'm also from a low middle income country. However, for some reason, we have a third dose. So there's an extreme contrast in our system that I can't explain. And back to the same question, if any of our other panelists would like to add. Okay, we have Mr. Rob.
I don't think I was next, actually. I think Uma, was it Uma I saw on the panel, I think might have had her hand up first.
I'm sorry, I didn't quite hear what you said.
I was just saying that I wasn't sure that my hand up was first, so I don't want to jump the queue. Uma, was your hand up, or was that from before?
I only saw yours and I can see Dr. Dennis.
Oh, okay. Uma, did you want to go first?
No, please go ahead. Go
Okay,
ahead.
just go, Mr. Go, and if anybody else, I will take them after you. Don't
Okay,
worry.
well, I'll be very quick then.
Don't worry.
The point I was going to say, really emphasize what Ines was saying, that of course, medical students are on a daily basis contributing, wonderfully, and that's just brilliant. And I think populations the world over are appreciating the efforts of medical students in helping care for their populations. But I do think, and this does reflect on your point, about the importance of getting involved in the politics of all this, sort of because, I would say that societies do, hold doctors in very, very high esteem. That they listen to what they're saying. You're in a very privileged position there. And therefore, I do think it is important to go the extra mile and get involved in the politics of this, because you'll be seeing on a day-to-day basis the inequalities, the unfairness. And I think, therefore, you are in a good position to challenge your governments and our governments, to be more accountable. And, where you are seeing failures of governments to allocate sufficient funds to provide you with the equipment you need and the resources that you need, they should be calling that out and engaging with the media, appearing on television, appearing on the radio, and engaging in political processes to challenge our leaders to do better. Because it is scandalous that particularly the wealthy nations, in not showing solidarity around the world, that we've seen in things like the G7 process that the UK chaired in June. We did practically nothing to help vaccinate the world, and in fact, we are blocking the patent waivers that are needed to enable more countries to make vaccines for everyone. So I think don't be afraid of getting involved in politics, and maybe join political parties. Here in London, my local MP is an A&E doctor, and she's now a shadow minister. And she speaks passionately in the House of Commons when she sees the failures of our NHS at the moment to provide services that everyone needs. So very much encourage you all to get stuck into the politics of all this, because as we keep saying, it's only political commitment that will change these things. And I think you're in a great position to get involved politically, and really encourage you to do so. Thank you.
Very much, Mr. Rob and Dr. Dennis.
Yes, thank you very much. I of course fully agree with what Robert just said. I think it's the commitment, your involvement in the politics is absolutely key. And I think also that the role that you are playing as medical students to help. Especially if you're already at the level of being in hospitals, to help the professionals in taking care of all these people is very important. I maybe one additional thing that I would like to share with you for your consideration. I know that in many countries the trend is really to get more specialized, to have people who are knowing as much as possible on diseases or areas of health that are becoming increasingly narrow, and that's a good thing, because it means that we know more and we can do more, and we have to make sure that we understand all the aspects of that. But on the other hand, I think one of the problems that we had, if I see in my country, Belgium, or in France or in Switzerland, is that we had certainly a lack of people ready and all working and knowing exactly what is happening at the community level. And as I said earlier, that we are able to catch what the people are really demanding and what they are happy with, what they are happy to share with the politicians. And you can play, as a little bit as Robert said, you can play a kind of role of relay between the communities, the people, the population, and the politicians. But for that, it's on not only virologists or epidemiologists, it's also GPs. And me, I would like to plead for having more of you embracing the profession of general practitioner and being as close as possible to the communities. It's for me a noble part of the work of medical doctor. And I think that, of course, we need specialists, but we also need to have a solid network of general practitioners. And there are places in European countries where it's difficult. In France, for example, you have what they call the medical deserts that are a reality, and you have to do I don't know how many. It's also the case in many other countries, and I would push for having and strengthening the network of primary care. That is for me that has been a little bit overcome in the management of the crisis, the decision making, and what just asked to do this, to do that, to do this, to do that, instead of involving them and therefore the population in the decision making. Thank you very much.
Sorry, I was muted. Yeah, okay. So first I'm thanking you, Dr. Dennis, and we can take Oma since she was also a presenter. However, also I would like to remind that the space for questions is in the end. So Oma.
Thank you. I just want to add a statement that I agree with Anis, Dr. Roberts and Dr. Dennis, and medical students don't just serve as students. We serve as a group of global health advocates, a group of skilled individuals who are capable of saving lives when necessary, such as the COVID pandemic, where in a lot of low and middle class income countries, students were actually working in COVID facilities. And given the right platform and the right skills, like IFMSA provides us, we are capable of doing a lot more than what we are right now as well. Thank you.
Thank you, Uma. And you and Ash speak on behalf of all of us medical students in this meeting and everywhere. And now we'll be moving to my last question. Then we'll be opening the space for questions by the attendees. And my next question is, how could countries improve and strengthen their health systems to achieve UHC and be prepared for any pandemic? Because as we have heard over the past 2 years, the pandemic will happen again. And this one didn't even stop yet. So it is certain that there will be another pandemic. So how can we be prepared? Who would like to start?
Yeah, happy to jump in. I think really what this has shown, is that countries have been underinvesting in health and health services. The fact that we have been hit like this and hits services from hospital services to palliative care to health promotion and obviously preparedness, has indicated a lack of political commitment and public financing to health. So it's a matter of reversing those processes, really, we need much greater political commitment. Health needs to be much higher on government's agendas. And you can see Governments like, the Chinese government are sort of saying quite explicitly now that we need to perhaps be giving a greater priority to health, even over, an obsession over economic growth and development. Health should be a right and a goal in its own right. And WHO in its work in the economics of health for all with Mariana Mazzucato are saying this as well. Much greater attention to health and well-being for societies. And that's going to require greater investment. It's going to require more public spending. And I can't emphasize enough the public aspect of that, because a market-driven health system will never achieve these things. You need the subsidies to come from the wealthy to make sure that everyone gets the full range of services that they need. So you need that public spending as well. And clearly we need to be spending that better. I think what this has shown up, have been cracks in our UHC systems. Here in the UK, we haven't given enough attention to social care and the interaction with long-term care of the elderly. Other countries have seen cracks when it comes to migrant populations. But I think pretty much everywhere has got to acknowledge we haven't been investing as much in the public health systems, the preparedness systems. So as we increase public spending, we need to be spending more of it on preparedness and public health services. So, those are the basic ingredients, but then obviously each country will have their own issues to deal with. But, and these are all head of government issues. We need to go way beyond, packaging this up for the Ministry of Health, even the Ministry of Finance. This is an all of government thing, and therefore this is a head of state, head of government issue. And we need to be seeing our overall leaders taking a lot more attention to the health system than they have done previously. Thanks.
Thank you, Mr. Rob. Dr. Dennis.
Yes, thank you. Thank you very much. I would like to say that in fact we have already a number of tools that were developed by the WHO and by the member states. We have the international health regulations. We have a number of tools that have been designed in the frame of the COVID-19 crisis, and I think that this is important because they are, in my sense, the foundations on which we can build something that needs to be more effective in the future. Because what we saw is that those tools were, I would say, slightly or dramatically neglected by the countries and were never really put in place. While we know that the measures that are proposed in for example in the international health regulation are important, but it's not enough. The second thing I want to say is that once again we need to organize the debate and the policy dialogue at country level. And I think what a practical measure or action or intervention, but a practical action that I think would be implemented in the country is to create or to organize a platform at the national level where these things can be discussed, and we envisage with the different kind of professionals, but also with the population, the politicians, the parliamentarian, and the people who are interested in the civil society to take care of this or to take part in this process, would be to try to see, okay, what do we know, what are the major lessons that we can learn from this crisis, but also maybe from the Ebola crisis in 2015, the Zika, the first SARS-CoV at the beginning of the millennium. And I think that this is certainly something that we should discuss all together and see, okay, what do we want to do? Where do we want to go? And what are the boundaries that we have? What are the constraints that we have in terms of availability of people, of professionals and qualified people, in terms of money, in terms of importance that these things can have for the society. Let's even imagine that maybe the next epidemic will hit not the elder, but the youngest people. Our reaction will be completely different, because it will not be our fathers, our mothers, our grandparents. It will be our children. And I think that this has to be put on the table. What do we do? What are we ready to go to if it's necessary? And we have now in many countries, contingency plans. We have emergency plans, and we have certainly strengthened that since 2 years now. But it has also to be a little bit prospective and anticipate a little bit what could happen if something very bad comes and has consequences that might be different from what we have now. So this kind of thing for me are really important to think about and to put in place. And I think that the young people, the young professional that you all are, have a role to play in that, because you can be in the instances, in the institutions, as a kind of political or citizen commitment or involvement. You can try to make this move forward and be tackled in a proper way. Thank you.
Thank you very much, Dr. Dennis, and of course, Mr. Robert. And now we will be moving to our final 10 minutes and our final part of this panel, which is open space for the participants to ask questions. Please try to include which panelist is the question directed to, so we can have an efficient discussion. Just type it in the chat and I will read the question. And you can also follow Mr. Robert on Twitter, as you can see in the chat. I will do for myself at least. Wait, okay, is the question? Again, if you have any questions, please type them in the chat and indicate the panelist.
Can I ask one question?
Of course.
Not to me or to Rob, but to you as students, because okay. I think that today's topic is really important, because it carries, in fact, the future of the profession that you have decided to embrace. And the job of medical doctor, when I was a medical student 35 or 40 years ago, it was not at all the same as what you can see now is important. And even in those universities where the clinical work is still very important and at the center of the training, which of course is a good thing, we have an increasing trend to open the discussion beyond medicine, beyond the medical aspects of health, and make sure that so my question, that we can respond to the real needs of the population in a kind of comprehensive and systemic way. So my question is, are you comfortable with that with regard to your training? do you think that what kind of additional knowledge and experience do you think would be required to become this kind of modern health professional that is happy to encompass and bring together a lot of different aspects of health related issues? How do you feel about that? Because that's for me a very important question also. Thank you.
Okay, I am sorry, Mr. Robert. We'll just take Inash's answer to that question and then we'll move on to you. Inash?
Yeah, I'm just going to answer taking into account my experience in Portugal and as someone that just graduated from medical school as well. So truth is that I believe that the first thing is actually, and what I saw within my medical colleagues, is that a lot of people don't even know like what global health is or what it exists, what it is even talked about like in global health in general, or like they don't know that we are having a migrants crisis, for example. And so if people aren't aware of these situations and medical students, how can they ever become interested in knowing more and being involved on a political level? So I really think that the first thing is actually education, which can be done either through inclusion in the medical curriculum as mandatory. I was fortunate enough to take, like, say, an elective course on global health because my medical school had that, gave us that opportunity, but it was elective, which means that only 15 out of the whole year did it. So yes, and besides inclusion in the medical curriculum, I also think that here, both national organizations, medical students organizations, but also the local ones, which is like the ones that belong to the medical school, they can play a huge role because they are led by medical students that can actually advocate on that inclusion on a local level, and that they themselves can actually organize activities and can actually bring the global health world to the agenda of the universal. So, and the other thing is because when we, and this is why it's so important, like that you are also here with us, because when we have, let's say, experts with us that actually bring a lot of added value to our discussion, this is also a signal for us that it's very important for us to get involved in this, and that we should keep learning and trying to, you know, like as you were saying previously, to actually get involved on a political level, because health is political and it will always be. So it's very important. At least I have this idea that health is political, and I know that it's important to understand the political side of it, but I also understand that a lot of people don't have it, and that they don't get to know enough of this political world, or who influences who, or about European Union, or about many other global health mechanisms. So yes, yeah, this is just, I try to be short and just a summary of what I think, but of course, I believe that my friends would like to add something. So yeah.
Yes, thank you.
Okay, so now I'll be speaking as a medical student. Okay, so in the beginning, I didn't introduce myself correctly. So I'm also the capacity building, the external affairs capacity building assistant, which is very in short. I try to provide the knowledge, the extracurricular knowledge, whether on global health, UHC, policies, anything related to health that is not taught in schools, through our peer education platforms. So this is basically what I do in IFMSA and what have I been doing for the past few years. So just the fact that this position exists indicates that we are not taught about this enough in medical universities or in medical schools. And this is a fact in my country, I'm sure about that. And I'm also sure this is a fact in multiple countries as well. Most countries do not have the opportunity to have elective courses as Portugal. But as far as we can do in IFMSA, we try to provide that knowledge through our channels, through even webinars, through panels like this, through workshops, through anything that we can provide. Hopefully, with time, it can be included in the curriculums at some point, hopefully in not the very far future. And just before Carly and Lily, Dr. Robert, you had your hand raised, and I'm very sorry that I didn't give you the floor before.
Oh, no, don't worry. I don't want to interrupt the flow of this discussion, really. I was going to ask about something else. So if Carlotta and Lily want to address this very important question, please come back to me later.
Okay, thank you. Okay, Carly and Lily, and we'll try to keep it short.
Yes, sure, thank you. So I think I agree with everything that you, Ines, and Adam mentioned. And I just wanted to add my own perspective, because I believe that Ines has a good point in saying that health is political, and I believe it is in many ways. And as someone who's always been fascinated by public health concepts and the opportunities, I feel like there is still a lot to do to help young people get into the political side of it. In our curriculum in Vienna, we have a mandatory part on public health, but most people just regard it as something that they have to do, and they are not really, we are not really taught any specific skills or anything. When it comes to what we might need, personally, I think, especially in Austria, I feel like the political side is very frustrating, in the sense that it becomes very personally attacking sometimes. So I believe something that might be good as a skill, in addition to medical knowledge, because I felt like I had to know everything in order to become politically active in any way, is to have a foundation of just general discussion and interaction skills, and how we can have like debates and properly and where to have them. So I think also something that has been mentioned before by Dr. Porignon, for example, is to have a platform where things can be discussed. I think that would be very helpful. Thank you.
Thank you, Carly. Lily?
Yeah, so I just wanted to like reassure what Ines said, because I strongly agree with what she said when the doctors were asking about what can medical students do to get involved or to contribute to UHC. My first thought was advocate for global health topics to be included in our medical curricula. So I strongly agree. And I think Dr. Robert asked if we were satisfied right now with the knowledge that we're getting, and I am not. That's my answer. I am definitely not. I had the opportunity to know all about IFMSA since I was in my first year of medical student. And that's the way that I got to know all about public health, and I'm so passionate about it. And it was so sad and demotivating when I started getting in depth into my medical career, and to see that I only had one subject that was about public health, and it was nothing. 4 months of public health is not enough. And yeah, I think that one action that we can take as medical students that are actually involved in this and that actually know the importance of all of these global health topics is to raise our voices together and go to our administratives at our med schools and start a conversation with them. If we don't raise the conversation, they're probably not going to do it. They're going to think that we don't care, but we actually care. I think that we have to raise our voices. And if we do it together, I think we're going to have a big impact. So yeah, that's my.
Great, thank you.
Thank you very much, Lily. Okay, so now we have reached the end of our official time. However, if Dr. Dennis and Mr. Robert would like to stay a little over time to address his last question, it's up to you.
Yes, please go ahead. Robert, go.
Okay, so.
Yes, thank you. Unfortunately, I will have to drop off in 5 minutes, but I've thoroughly enjoyed today's session and delighted to see you all sort of so passionate and committed, particularly to the politics of all this. And I suppose really just one sort of word of encouragement, I suppose, that whereas it might feel difficult at the moment, all our UHC systems have been hit quite hard. I think that when you look through history, you can see that so many of the world's great UHC systems have come out of crises. You know, that if you look at here in the UK and Japan and France, it was really the Second World War that catalyzed their transitions to universal health coverage. Thailand after the Asian financial crisis. China really re-socialized its health financing system after the SARS epidemic. Sri Lanka as well after epidemics in the 1930s and 40s. So now is the time, I think, really to be going for this. And you know, that we do have the ears of our political leaders at the moment. And you can see that a lot of political leaders are being judged on their COVID response, you know, that it was largely the reason that President Trump got voted out. I think we're going to see something similar happen in Brazil with President Bolsonaro. And I deeply hope we're going to see the same thing here in the UK with Boris Johnson. You know, it's his approach to COVID that is making him very unpopular at the moment. So this is our opportunity. And I think if you are passionate about UHC, now is the time to take to the airways and fighting for it. And we're optimistic we're going to see more UHC systems come out of this. And we at Chatham House are passionate about universal health coverage and the politics of it. So if any of you are interested in this, want to follow up, particularly if you have links with political leaders who might be wanting to really champion UHC coming out of this. They might not be in government at the moment. They might want to run for president or prime minister on this, and we'll be only too happy to help and support, advise on those processes. So I think we can be optimistic, and this is what we should be fighting for going forward. Anyway, thanks so much for involving me today. It's been wonderful. Thank you.
Okay, before we go to Dr. Dennis, just before Mr. Rob drops out, we'll all have a picture and then I will give you the floor, okay?
Okay, great.
Okay, so now picture time. Carly, can you help us with that?
Yes, sure, I can try. Give me a second to get everyone on the screen. Okay, I will have to take two, I think, because we are too many.
Okay.
So everyone, you can open your cameras if you would like to. It's also fine to leave them out if you don't. And I will take a picture in 1, 2, 3. I think that worked, but I will take another one just in case. Okay, 1, 2, 3. Perfect. I think now we have everyone.
Okay, thank you very much, Carly. And now to Dr. Dennis.
Yes, just to say also a big thank you. Congratulations for organizing this kind of session. I think we were about 30 this year. I hope and I guess that next year we will be 300. Thank you very much.
Thank you all for joining us today. Special shout out to our panelists and our VPE and all our presenters and everybody who enjoyed this. Don't forget to follow Mr. Robert on Twitter and to check the links that both Mr. I can't remember who sent the links, but just check all the links in the chat. Okay, so this is it. See you hopefully all next year. Bye.
Fantastic. Stay well, everyone.
Thank you, everyone.
Bye.
Bye, Ines. Thank you very much.
Bye. Thank you very much.